Welcome back to the deep dive. Today we are doing something a little different.
A little bit.
Usually we take a very specific topic, like a single virus or maybe the new treatment, and we really drill down. But today I've got Murray's Medical Microbiology open to chapter 15, and I mean, it feels like we're zoomed out to the 30,000-foot view.
We absolutely are. And, arguably this is the most important view you can possibly have as a student.
The chapter title is just Role of Bacteria in Disease. It sounds incredibly broad, but as I was reading through this, I realized this isn't just a collection of general info. This is kind of the grand unified theory of how you get sick.
That is a fantastic way to put it. Most students, they spend their first couple of years of med school in what I like to call the bug parade.
The bug parade, I love.
You memorize Staph aureus, then you move on to strep pyogenes, then you do E. coli. It's just this endless list of names and properties. It can feel like you're memorizing a phone book.
I feel that. I have my flashcards right here, and it's just overwhelming. Positive coagulase, negative oxidase. It's just a sea of data without a story.
Exactly. So what Murray Chapter 15 does, and what we're going to do today, is flip the script entirely. We are stopping the parade.
Okay.
We're not going to look at who the bacteria are, but what they are doing. We're moving from the noun to the verb. Because look, whether it's a tiny little streptococcus or a massive bacillus, they all have to solve the exact same problems to survive inside a human body.
They have to get in, they have to find a place to stay, and they have to avoid getting killed by our immune system.
And in the process of doing all that, they cause what we call disease. So if we use Murray as our roadmap, as our sort of structural spine, and then we layer in the mechanisms from Jack's Chapter 9, we can actually build a logic engine.
A logic engine?
Yeah. So instead of just memorizing that E. coli causes UTIs, you'll actually understand why it has the specific grappling hook it needs to climb up the ureter.
Which means when I'm staring at a patient or, more likely an exam question, I'm not just guessing, I'm deducing, I'm thinking through the problem.
Precisely. That's the goal.
Okay, so let's start at the very beginning of the chapter. Murray lays out this concept he calls a triad. He says disease isn't as simple as just bug meets human. It's more complicated.
Right. It's a great concept. If I put a really virulent bacteria on the table right next to you, you don't automatically get sick. The triad is what determines the outcome.
Okay, so what's in the triad?
Factor one is the bacteria itself. What weapons does it bring to the fight? That's its virulence potential. Factor two is the host. That's you.
My immune system, my age.
Exactly. Do you have antibodies from a previous infection? Are you stressed? Do you have some underlying disease or a genetic defect? All of that is the host side of the equation.
And factor three?
Opportunity.
Opportunity. That sounds a little bit like a crime drama, means motive and opportunity.
It's actually a very similar framework. Opportunity is all about the interaction. You could have the deadliest bacteria in the world, like, say, Francisella tularensis. But if it doesn't have a route of entry, if it never meets your mucous membranes or a break in your skin, then no disease occurs.
So it's just sitting there.
It's harmless. But on the other hand, you can have a totally wimpy bacteria, something that lives on your skin every single day, like Staphylococcus epidermidis. It has almost no weapons to speak of.
Right.
But if you give it the opportunity, say, by shoving a plastic catheter through your skin and right into your vein, it suddenly becomes a stone-cold killer.
That really brings up a framework from Jarwitz that stuck with me. They call it the damage response framework. I think, as a layperson, I always assumed infection was a binary switch. You're either clean or you're infected.
That's the old way of thinking, for sure. The reality is much more of a continuum. I mean, think about it. Right now, your gut is absolutely full of bacteria, trillions of them. Are you infected?
I mean, no. They're supposed to be there. They're my friends.
Technically, you are colonized. The spectrum really goes like this. First, you have elimination. The bug hits you, your immune system just says absolutely not and kills it instantly. You never even know it happened.
Okay.
Second, commensalism. The bug moves in, it sort of pays rent, maybe it helps with the dishes, like making vitamin K in your gut. It causes no trouble at all.
And that's the healthy gut microbiome we hear so much about.
That's it. Then you have colonization. Now, the bug is multiplying, it's taking up space, but it's not actually hurting you. You might test positive on a swab, but you have no symptoms.
This is like being a carrier, right?
Exactly like that. Think of Typhoid Mary. She was colonized with Salmonella typhi, but she wasn't sick in the symptomatic sense. She was just spreading it everywhere.
And the final step is?
Finally, you have disease. And the definition of disease is simply damage. But here is the kicker. And this is probably the most important concept in all of infectious disease.
Mm.
Where does that damage actually come from?
Well, from the bacteria, right? It's eating you. It's releasing poisons.
Sometimes, yes, absolutely. But very often, the damage comes from you. It comes from the host's immune response completely overreacting to the invader.
So, my own body is the problem.
The bacteria might just be sitting there minding its own business, but your immune system decides to drop a nuclear bomb to get rid of it. The fever, the inflammation, the swelling, the pus, that is your body damaging itself in an attempt to clear the infection.
So, in a war, the city gets destroyed not just by the invading army, but by the defender's own artillery fire.
That is the perfect analogy. And as we go through these bugs today, I want you to keep asking yourself that question. Is the damage I'm seeing caused by a bacterial toxin, or is it caused by the host's artillery?
I love that framework. Okay, let's get into the weeds. Murray organizes his chapter by the classic bug parade group, so we'll follow that structure, but we're going to pop the hood and break down the mechanisms. First up, gram-positive coochie. The heavy hitters, Staphylococcus and Streptococcus.
The staph and strep show.
Yeah, and when I look at the list of diseases they cause, I mean, skin infections, pharyngitis, endocarditis, pneumonia, it just seems like they're everywhere.
They are, and their number one problem, the very first hurdle they have to clear, is gravity and flow.
Flow. What do you mean by flow?
Think about where these bacteria live. Your throat, your skin, your urethra. These are all places with constant movement. You swallow, you sweat, you pee. The body is constantly trying to power wash these surfaces clean.
So the bug has to hold on for dear life.
Exactly. If you are a gram-positive coccus, your primary virulence strategy has to be adherence.
You have to be sticky.
You have to be Velcro. Murray talks about this whole class of proteins called MS grams, which is a terrible acronym, but it basically just means surface proteins that are designed to grab onto the host.
Microbial surface components recognizing adhesive matrix molecules. Yeah, that's a mouthful.
It's a lot. But let's look at a really specific example from Javits that, for me, just blew my mind. Streptococcus pyogenes.
That's group A strep throat.
Right. Now, have you ever tried to hold on to a wet, slippery rock in a rushing river? That's what strep is trying to do in your throat every single time you swallow. It needs a grappling hook.
And the book mentions things like lipoic acid and protein F. Those are the grappling hooks.
Let's focus on protein F. The F stands for fibronectin. Now, fibronectin is a protein that coats the outside of the epithelial cells in your mouth and your throat. It's like a sticky mat.
Okay.
Strep pyogenes has evolved a very specific surface protein that locks onto that fibronectin. It's not just some generic stickiness, it's a molecular lock and key mechanism.
So it's not just glue, it's more like a specific docking maneuver.
It's a targeted docking. Without that protein F, you could just drink a glass of water and wash all the strep right down into your stomach where the acid would obliterate it. With protein F, it holds on tight.
Okay, so that's the Velcro concept. But you also mentioned a bunker. I'm thinking of Staphylococcus epidermidis.
Staph epi.
Yeah.
Yes, this is the bug we talked about earlier, the really wimpy one that just lives on your skin. But in the hospital, it is the absolute nemesis of every surgeon.
Because of plastic.
Because of plastic, catheters, prosthetic joints, heart valves. Staph epi has this incredible ability to form a biofilm. Now, biofilm sounds like a thin, wet, slimy layer, but I want you to visualize a fortress made of concrete.
That's a strong image.
When staph epi touches a foreign surface like a catheter, it starts to secrete this slime. It's a complex exopolysaccharide matrix.
The book calls it a polysaccharide slime layer.
Which doesn't do it justice. It's basically bacterial concrete. The bacteria multiply deep inside this slime. And once they're encased in it, they actually change their behavior. They stop acting like individual bacteria and start acting like a coordinated colony.
How does that change things for treatment? I mean, if I give a patient antibiotics, won't the drug just soak into the slime and kill them?
You would think so, but no. That's the whole problem. First, the slime itself is a diffusion barrier. The drug physically can't get deep enough into the fortress to reach all the bacteria. But secondly, and this is the really clever part, the bacteria deep inside the bunker go dormant.
They hibernate.
They slow down their metabolism to almost nothing. They basically go to sleep.
And that matters because
most of our best antibiotics, like penicillin, they only kill growing bacteria. They work by attacking the cell wall assembly line. If the factory is shut down, the antibiotic has nothing to attack.
So the bugs just sleep through the bombardment?
They sleep through it. Then, as soon as you stop the antibiotics, they wake up, start multiplying again, and reinfect the patient.
And this explains why, clinically, you can't just treat an infected central line with drugs. You have to pull the line out.
You have to rip the bunker out of the body. There's no other choice. So if you see an exam question about a patient with a prosthetic device, maybe a new heart murmur after a valve replacement, or a chronic infection around a prosthetic knee, you have to think biofilm. You have to think staphylococcus.
It's a great clinical tie-in. Before we leave this idea of adherence, there was a little sidebar in the reading about E. coli. I know it's a gram-negative, so we're kind of jumping ahead a bit, but it just fits this stickiness theme so perfectly.
It does. It's a perfect example. E. coli is the absolute master of tissue tropism, which is a fancy way of saying it's really good at picking exactly which neighborhood it wants to live in.
And it does this with pili, right? These little hairs.
Right. Pili are these tiny hair-like projections sticking out from the bacterium. Now, your generic E. coli, the kind that gives you a simple bladder infection or cystitis, it has what we call type 1 pili. These pili stick to mannose receptors, which are all over the bladder.
So that gets it into the bladder.
But there is a much nastier version of E. coli.
The one with the papillary.
The P. pili. These are different. They don't stick to the bladder very well. They're specifically designed to bind to the P blood group antigen. And guess where the P blood group antigen is found in really high concentrations?
The text says the upper urinary tract, so the kidneys.
Exactly, the epithelial cells of the kidneys. So if a patient gets infected with an E. coli that has P. pili, that bug is not going to stay in the bladder. It is going to use those P. coli-like climbing ropes to ascend the ureters, lock onto the kidney tissue, and cause pyelonephritis.
And that is a huge clinical distinction, a simple bladder infection versus a full-blown kidney infection.
Oh, it's night and day. It's the difference between some burning when you pee and, high fever, terrible flank pain, and potentially life-threatening sepsis. And it all comes down to the shape of the tip of that one microscopic hair.
P. pili for pyelonephritis. That's a mnemonic that practically writes itself.
It really does.
I love that. Okay, let's move on to the next major group in Murray's list, the gram-positive rods. We're talking Bacillus, Clostridium, Corynebacterium, Listeria.
Okay, so now the theme shifts. We're not talking about sticking as much anymore. We're talking about toxin factories.
These are the ones that bring the chemical weapons to the fight.
And not just any chemical weapons. We're talking about precision-guided missiles. The classic mechanism here, and Jowett spends pages and pages on this, is the AB exotoxin.
AB, it sounds like a binary code or something.
It's a two-part system. The best way to think of it is like a letter bomb. The B subunit is the binding component. It's the envelope. It addresses the package to a specific receptor on the host cell and gets the toxin inside the door.
Okay, so B is for binding.
And the A subunit is the active component. That's the explosive charge inside the envelope.
So B gets it in, A does the damage.
Exactly.
Yeah.
Let's look at the absolute prototype for this, diphtheria, from Corynebacterium diphtheria.
This one used to be called the strangling angel of children. I mean, it's a terrifying disease.
It is. And the bacteria itself is actually surprisingly lazy. It just sits there in the back of the throat. It doesn't invade your blood. It doesn't go and eat your organs. It just sets up camp on your tonsils and starts printing toxins.
The toxin is what does all the traveling.
The toxin gets into the blood and goes everywhere. Now, here is the mechanism you absolutely have to visualize. The A subunit gets inside a host cell. Let's say it's a heart cell or a nerve cell. It has a very specific target, a protein called elongation factor 2, EF2.
I vaguely remember seeing EF2 in my biochemistry nightmares. Can you remind me what it does?
It's a crucial part of the ribosome.
Yeah.
It's basically the worker that moves the protein chain along the assembly line as it's being built.
Okay, the engine of the ribosome.
It's a perfect description. The diphtheria toxin performs a chemical reaction called ADP ribosylation on EF2.
ADP ribosylation, that's a mouthful.
It is, but think of it simply as throwing a wrench into the gears of that engine. It physically attaches a bulky molecule onto EF2 that freezes it in place. The entire ribosome just jams. Protein synthesis stops dead in its tracks.
And if a cell can't make protein,
It dies very, very quickly. And in the throat, this massive cell, death, creates a thick layer of dead tissue, fibrin, and bacteria. That's the famous pseudomembrane, that gray, leathery sheet that covers the airway and literally strangles the patient.
but because the toxin is circulating in the blood, you also get heart failure, myocarditis, and nerve damage or neuropathy.
All from a bug that never even left the throat. Now, here's a little detail from Jowett that adds a fascinating twist to the story. The bacteria doesn't actually want to kill you.
It has a funny way of showing it.
I mean, from an evolutionary perspective, the gene that makes this toxin is actually regulated by iron.
Iron again. It always comes back to iron.
It's the currency of war. When iron levels are high in the environment, the bacteria is happy. It has what it needs, so it represses the toxin gene. It doesn't make the poison.
But when iron is low?
When iron is low, when the bacteria is starving, a repressor protein falls off the gene, the factory turns on, and it starts pumping out toxin.
So it's a distress signal, a cry for help.
It's a smash-and-grab robbery. It kills the host cells to rip them open and get at their internal iron stores. The death of the child is just, collateral damage in the bacteria's desperate quest for lunch.
That is incredibly dark. But it makes a chilling kind of evolutionary sense.
It does. Now, speaking of powerful toxins, we have to talk about the Clostridia, specifically tetanus and botulism.
The famous mirror images.
This is one of the most elegant and beautiful comparisons in all of microbiology. Clostridium tetani and Clostridium botulinum are very closely related. They both produce incredibly potent neurotoxins. And mechanically, at the molecular level, they do almost the exact same thing.
They are both proteases, right? So they cut proteins.
Yes, specifically they are zinc proteases that cut the snare proteins.
The docking ropes.
That's the perfect analogy. Imagine a neuron trying to send a signal. It has a little bubble, a vesicle, that's full of neurotransmitter. To release that chemical signal, it needs to dock that bubble at the cell membrane. The snare proteins are the ropes that pull the bubble to the dock and fuse it.
And these clostridial toxins just cut the ropes.
Snip. They cleave the synaptobrevin protein. No docking, no release of neurotransmitter. The nerve terminal goes silent.
So if the mechanism is the same, cutting the ropes, why on earth does tetanus make you stiff as a board with lockjaw and botulism makes you as floppy as a rag doll?
It all comes down to three things. Location, location, location.
Okay, so where do they go?
Well, let's start with tetanus toxin. It gets into a wound, the bacteria grows, and it releases its toxin. The toxin enters the motor neurons, but then it travels backwards, we call it retrograde transport, all the way up the nerve to the spinal cord.
Okay, so it gets to the central nervous system.
And there it jumps the synapse and specifically attacks the inhibitory interneurons. These are the neurons whose job it is to tell your muscles to relax. They release inhibitory neurotransmitters like glycine and GABA.
So the tetanus toxin cuts the ropes on the relapse signal.
Exactly. Yeah. It disables the brakes on your muscles. Your motor neurons start firing completely uncontrollably. You get spastic paralysis. The back arches, the jaw locks shut, the face freezes in that horrible grin, the rhizus sardonicus.
Okay, now contrast that with botulism.
Botulism toxin is much lazier. It doesn't travel all the way to the spinal cord. It stays right there at the peripheral neuromuscular junction. It cuts the ropes on the motor neuron itself. It stops the release of acetylcholine.
And acetylcholine is the contract signal.
Correct. It disables the gas pedal.
Yeah.
You try to move your muscles, but no go signal can get through. The result is flaccid paralysis.
So tetanus cuts the brakes, which causes spastic paralysis. Botulism cuts the gas, causing flaccid paralysis.
Perfect summary. And historically, you think about how you get them. Tetanus is the dirty wound, the rusty nail. Botulism is the improperly home-canned beans. The toxin is preformed in the can. You're not getting infected, you're just eating the poison.
Which means botulism in an adult is technically an intoxication, not an infection.
For the most part, yes. The bacteria doesn't even need to be inside you. You just ate the toxin that it made in the jar. The exception is infant botulism, where the spores can colonize the gut.
Okay, before we leave the gram-positives, we have one major outlier on this list. Listeria monocytogenes. It's a rod, but it doesn't just sit outside and shoot toxins. You called it a ninja.
Listeria is my favorite bug to teach because its mechanism is just so incredibly cinematic. This is the bug that causes meningitis in newborns, pregnant women, and the elderly. You get it from things like unpasteurized cheese or contaminated deli meats.
And it actually invades our cells.
It forces the cell to eat it. It enters the phagosome, which is basically the cell's stomach. But before the cell can digest it, Listeria has a secret weapon. It releases a pore-forming toxin called Listeriolysin O. It punches a hole in the stomach lining and escapes out into the cytoplasm.
So now it's free, living in the safe space inside the cell.
Right. It's in the rich, nutritious cytoplasm, safe from harm. But here's the truly amazing trick. It hijacks the host cell's own actin network. Actin is like the structural scaffolding of the cell. Listeria has a protein on its surface, Act A, that polymerizes this actin into a tail behind it.
It builds its own rocket engine.
Exactly like a rocket engine. It builds this long tail of actin that propels it forward at high speed. It zooms around the cell, and then, get this, it slams into the cell membrane so hard that it pushes right through into the neighboring cell.
It just punches through the wall into the next room.
It forms a protrusion and gets engulfed by the neighboring cell without ever going outside into the extracellular space. It goes from cell to cell to cell.
Why does that matter so much clinically?
Well, think about your immune system. Where do your antibodies float around?
In the blood, in the fluid between cells.
Right. If Listeria never goes outside, your antibodies can never see it. They can't touch it.
So it's effectively invisible to the humoral immune system.
Completely invisible. That's why you need a very strong cell-mediated immune response, your T cells, to find and kill the infected cells. And who has a relatively weaker T cell response?
Pregnant women, neonates, the elderly, transplant patients on immunosuppressants.
The exact demographic that gets severe Listeria meningitis. The mechanism perfectly explains the risk factor.
That is just brilliant. Okay, let's take a deep breath. We are crossing the Great Divide. We are moving on to Section 3, the gram-negative.
The pink stains.
Whole different world.
You've got Neisseria, E. coli, Salmonella, Shigella, Pseudomonas. This is a huge and diverse category.
And the rules of the game change here completely. Gram-positive was all about thick cell walls and secreted toxins. Gram-negative is about complex machinery and the cell wall itself being toxic.
Let's start with that machinery.
Yeah.
Jades talks about these things called secretion systems, specifically the type 3 secretion system, or T3SS.
Ah, the injectosome. My favorite.
It really looks like a tiny needle. Under an electron microscope, it looks exactly like a hypodermic needle sticking out from the surface of the bacteria. This isn't about passively releasing a toxin into the environment and hoping it finds the right cell. This is about docking with a host cell, punching a hole in its membrane, and injecting effector proteins directly into the cytoplasm.
It's like mainlining poison directly into the cell.
It's more like hacking.
Okay.
Take Salmonella, for example. It swims up to an intestinal epithelial cell. Now, these cells are not phagocytes. They're not designed to eat bacteria. They're just supposed to be a wall.
Right.
Salmonella uses its injectosome to squirt proteins inside that completely scramble the cell's actin cytoskeleton.
The textbook says it causes membrane ruffling.
It does. Imagine the cell membrane suddenly bubbling up and wrapping around the bacteria like a splashing wave. Salmonella literally forces the cell to engulf it against its will. It hacks the cell's own operating system to trick it into opening the door.
That is a terrifyingly sophisticated weapon.
It is. And Shigella does the same thing to get inside cells in the colon. Pseudomonas uses its needle to inject poisons that just kill the cell outright. It's a loaded gun.
Okay, so that's the loaded gun. Now let's talk about the other big concept here. The structural poison, endotoxin.
This is, without a doubt, the single most important concept you need to understand for gram-negative sepsis. You have to know the difference between an exotoxin and an endotoxin cold.
Okay, so exotoxin is what we talked about with diphtheria. It's a protein that the bacteria makes and actively sends out.
Correct. Endotoxin is not a protein. It is lipopolysaccharide, or LPS. It is a structural brick that is an integral part of the outer wall of every gram-negative bacteria.
So the bacteria is literally wearing the poison.
Yes. And the really dangerous part is a lipid component that's buried in the outer membrane called lipid A. Now, as long as the bacteria is alive and its wall is intact, that lipid A is mostly hidden from your immune system. But what happens when your immune system starts killing the bacteria, or when you give antibiotics that blow up the cell wall?
The bacteria lyses, it explodes.
And millions of tiny shards of its cell wall, all containing lipid A, suddenly flood into the bloodstream.
And the immune system sees this lipid A and freaks out.
It panics.
Yeah.
Your macrophages have a receptor complex, CD14, and toll-like receptor 4, TLR4. When lipid A binds to this complex, the macrophage doesn't just send a localized "we need some help" signal. It pulls the 5-alarm fire alarm for the entire body.
It releases a flood of cytokines.
A cytokine storm. It dumps massive amounts of interleukin-1, IL-1, interleukin-6, IL-6, and especially tumor necrosis factor alpha, TNF-alpha.
We need to know this cascade cold for exams. What happens when these hit the system?
IL-1 travels to the hypothalamus in your brain and resets your body's thermostat. That's what gives you the high fever.
And TNF-alpha, what does that do?
Tumor necrosis factor. It has a profound effect on your blood vessels. It causes widespread vasodilation. Your blood vessels get wide and floppy, and it increases their permeability, making them leaky. Fluid rushes out of your bloodstream and into your tissues.
So your blood pressure just tanks. That's hypotension.
And that's the definition of shock, septic shock. But at the same time, this cytokine storm is also activating your clotting cascade all over your body. You start forming thousands of tiny microclots in your small blood vessels. This is DIC, disseminated intravascular coagulation.
So you start clotting everywhere, you use up all your clotting factors, and then you start bleeding to death from your IV sites and everywhere else.
Precisely. Fever plus hypotension plus DIC. That is the classic triad of gram-negative sepsis. And notice the pattern here. The bacteria didn't attack you with a toxin. You attacked the bacteria, you blew it up, and the debris from its dead body caused your own immune system to go haywire and try to kill you.
It really hammers home that idea that the host response is often the real killer.
100%.
Before we move on to the gut bugs specifically, I want to quickly touch on Neisseria. So gonorrhea and meningitis, they have a really specialized trick that involves our antibodies.
The IgA protease,
Ugh.
a very clever weapon.
So IgA is the antibody that lives on our mucosal surfaces, right? In our mucus.
Yes. It's the bouncer at the club. It lives in your throat, your urethra, your gut lining. Its job is to grab onto bacteria and clump them up so they get flushed out before they can ever attach. It's like molecular handcuffs.
And Neisseria.
Neisseria comes equipped with a pair of molecular bolt cutters. The IgA protease is an enzyme that specifically finds and snips the hinge region of the IgA molecule, breaking it in half.
It cuts the handcuffs.
It renders the antibody completely useless. This is what allows Neisseria to colonize and live on mucosal surfaces where most other bugs would just get swept away immediately.
And gonorrhea has another trick that honestly drives me crazy as a student. Why can't we make a vaccine for gonorrhea? It feels like we should have solved this by now.
Antigenic variation. It's the ultimate disguise artist. So Neisseria gonorrhea uses its pili to stick to urethral cells.
Yeah.
Your body sees those pili, let's call a protein on them, pilin A, and it starts making antibodies to attack pilin A.
Right.
But the bacterium has a whole library of silent genes genetic cassettes for different versions of a pilin protein that it can swap in and out of the expression site.
It changes its code.
Constantly. While your immune system is busy making antibodies for pilin A, the bacteria just switches its gene and starts expressing pilin B. Your anti-antibodies are now completely useless. By the time you mount a response to B, it's already switched to C.
It's playing a shell game with your immune system.
It is. And Murray says the rate of switching is incredibly high, like 1 in every 1,000 bacteria. So in any given colony of gonorrhea, there are always variants present. This is why you can get gonorrhea over and over again. There's no lasting immunity because to your immune system, it's a new bug every time.
That is just frustratingly clever. Okay, let's pivot and move to section 4. The enteric diarrheas.
And the stomach bugs.
Yeah, and Murray has a table here with what feels like 15 different organisms that all cause diarrhea. It's a mess. How do we organize this for an exam?
Don't memorize the list. That's a fool's errand. You have to divide them by mechanism. There are essentially only 2 ways to get diarrhea. Secretory, which is watery, and inflammatory, which is bloody.
Water versus blood, that's a clean distinction.
Yeah.
Okay, let's do water first. And the king of watery diarrhea is cholera.
Vibrio cholerae. This is a pure toxin-mediated disease. The bacteria does not invade your tissues, it doesn't cause any inflammation, it just sits on the surface of the intestine and releases its cholera toxin.
And the mechanism here.
It's an AB toxin again. But this one performs ADP ribosylation on a specific target, a stimulatory G protein, GS. It permanently jams the on switch for an enzyme called adenylate cyclase,
Which cranks up the production of KMP inside the cell.
and persistently high levels of KMP activate the CFTR channel, which is a chloride pump. It starts pumping chloride ions out of the cell and into the gut lumen like crazy.
And where the salt goes.
Sodium follows the chloride to balance the charge, and water follows the sodium to balance the osmosis.
So the intestinal cells are just relentlessly dumping water into the gut.
Massive amounts. This is what causes the classic rice water stools. A patient can lose 20 liters of fluid a day. You can literally dehydrate and die in a matter of hours. But, and this is a key differentiator, if you were to look at the gut lining, there would be no physical damage, no ulcers, no blood. It's just a plumbing problem.
Okay, now let's contrast that with the bloody diarrhea group. Let's talk about Shigella.
Shigella is the honey badger of the gut. It does not just sit on top, it invades. It targets the M cells in the Peyer's patches of the colon, uses that type 3 secretion needle to force its way inside, and then, just like Listeria, it uses an actin rocket to tear through the tissue laterally from cell to cell.
So it's physically destroying the mucosal lining.
It's ripping it to shreds.
Yeah.
That causes intense inflammation, ulceration, and bleeding. That's what gives you dysentery, frequent, small volume, bloody mucus-filled stools. It's very painful.
And the really bad one, Shigella dysentery, also has a toxin.
It does. The Shiga toxin. This one also attacks the ribosome, but it does it differently from diphtheria. It's an enzyme that cleaves the 60S ribosomal subunit, which inactivates it, stops protein synthesis, and kills the cell that way.
Now here's where a lot of students, myself included, get confused. E. coli shows up in both of these lists.
E. coli is a master shapeshifter. E-tech, or enterotoxigenic E. coli, is the cause of traveler's diarrhea. It acts exactly like cholera. It makes a heat labile toxin that increases KMP. It causes a watery diarrhea.
Okay, so E-tech is in the watery camp.
But then you have EHEC, or enterohemorrhagic E. coli, the famous O157HE7.
This is the undercooked burger bug.
That's the one. E. coli is essentially an E. coli that, at some point in its evolution, stole the toxin gene from Shigella. It produces Shiga-like toxin.
So it causes bloody diarrhea like Shigella?
Yes. But here is the specific danger that makes it so feared. The Shiga-like toxin has a particular affinity for the endothelial cells that line the glomerulus of the kidney.
Which leads to HUS hemolytic uremic syndrome.
Exactly. Kidney failure, shredded red blood cells from passing through damaged capillaries, which causes anemia, and low platelets that get used up in the clotting. It's a true medical emergency. And here is the clinical pearl that could save a life on an exam or in the clinic. If a child comes in with bloody diarrhea and you suspect EHEC, you generally do not give antibiotics.
Wait, you don't treat the bacterial infection?
If you stress the bacteria with an antibiotic like a chloroquine alone, it panics. It induces its SOS response. And what do these bacteria do when they panic? They upregulate the production and release of the toxin.
You make it worse.
Multiple studies have shown that the use of antibiotics in EEC actually increases the risk of developing HUS. The standard of care is just supportive care. You just have to support the patient and let them clear the infection on their own.
That is incredibly counterintuitive, but absolutely crucial to know. All right, let's shift gears and hit section 5. Special clinical patterns. This is rapid-fire pattern recognition based on Murray's tables. Let's talk lungs.
Respiratory infections.
Top of the list, Streptococcus pneumonia, pneumococcus.
The number one virulence factor here is the capsule. It's a thick, slimy sugar coating around the bacteria.
It's like an invisibility cloak.
It's more like a slippery suit of armor made of Teflon. Your phagocytes, your white blood cells, they try to grab onto the bacteria to eat it, but they just slide right off. They can't get a good grip.
So it's antiphagocytic.
That's the term.
Yeah.
And this is why your spleen is so important. It's the body's superfilter that is specially designed to catch these encapsulated bugs. If you don't have a spleen, if you're a splenic, strep pneumo can kill you very quickly.
And the quelling reaction, I always see that associated with it.
That's the classic lab test. You take the bacteria, you add specific antibodies that bind to the capsule, and the capsule swells up under the microscope. Quelling literally means swelling in German.
Okay, what about Pseudomonas in the lungs?
We mentioned it earlier with the injectosome, but clinically, the word you must associate with Pseudomonas is cystic fibrosis. In the CF lung, Pseudomonas produces a unique biofilm made of a substance called alginate. It's a thick, rubbery mucoid slime.
And it's impossible to clear.
It's impossible for a CF patient to cough out. And it has a very distinctive smell in the lab, like grapes or sometimes corn tortillas. And don't forget, it produces exotoxin A, which has the exact same mechanism as diphtheria toxin, ADP ribosylation of EF2.
Okay, let's go to the anaerobes, the stinkers. I'm looking at Clostridium perfringens.
Gas gangrene. This is a true horror movie infection. It happens in deep, crushing trauma motorcycle accidents, battlefield wounds. The tissue loses its blood supply, goes anaerobic, and the dormant C. perfringens spores wake up.
And it produces the deadly alpha toxin.
Alpha toxin is a lecithinase. Now, lecithin is a phospholipid that is a major component of all your cell membranes. This toxin is an enzyme that splits lecithin.
So it literally melts the cell membrane.
It turns muscle tissue into a soupy, necrotic mess. That's myonecrosis. And as the bacteria ferments the sugar in your dead muscle tissue, it produces huge amounts of gas.
And that's where the name comes from. You can feel bubbles under the skin.
Crepitus. You can palpate the skin, and it feels like pressing on bubble wrap. And the smell is described as a foul dishwater pus. This requires immediate, aggressive surgical debridement, cutting out all the dead tissue. Antibiotics alone are not enough because there's no blood supply left to deliver them to the site.
Terrifying. Okay, let's do a quick run through on the zoonotics and vectors.
Lyme disease caused by Borrelia. Think ticks, specifically the Ixodes tick. Think of the classic bullseye rash, erythema migrans.
Rocky Mountain spotted fever caused by Rickettsia rickettsii.
Also ticks. Think of a rash that classically starts on the palms and soles and then moves inwards towards the trunk.
And Francisella tularensis.
Tularemia, or rabbit fever. Think of hunters skinning rabbits or even landscapers running over rabbit nests with a lawnmower and aerosolizing the bacteria. It's famous for its incredibly low infectious dose. You may only need 10 organisms to get sick.
Only 10? That sounds like biological warfare grade.
It literally is. It is classified as a Category A bioweapon agent.
Wow. Okay, let's go to our final section, iron. We've touched on this a couple of times, but let's really bring it home.
Iron is the currency of life. We need it for our enzymes. Bacteria need it for their enzymes. The human body has evolved to hide its iron with incredible efficiency. We keep it locked up inside hemoglobin or bound tightly to transport proteins like transferrin in the blood and lactoferrin in mucus. We have almost zero free iron circulating in our blood.
It's a scorched earth policy to starve any invaders.
Exactly. Nutritional immunity. But of course, the bacteria fight back. They have evolved their own weapons, cytophores.
Cytophores.
These are small molecules that bacteria secrete. They have an unbelievably high affinity for iron, even higher than our own transferrin. They were like iron magnets. They go out, rip the iron off of our proteins, and carry it back to the bacteria.
So it's a constant tug of war for this one resource.
It is. And here is the aha moment for clinical medicine. When you have a chronic infection, your liver produces a hormone called hepcidin, which tells your body to hide iron even better. Your serum iron levels drop. You start to look anemic on your lab work.
This is the anemia of chronic disease.
That's it. And what does a well-meaning but perhaps naive doctor do when they see anemia on a lab report? They prescribe iron supplements.
But if you give iron supplements to a person with an active bacterial infection...
You are feeding the enemy. You are giving them the one resource they are fighting for. There have been studies where giving iron to patients with sepsis or malaria actually worsen their outcomes. You have to respect the body's ancient strategy. Don't just treat the number on the lab report. You have to understand the war that's being fought.
That is a very powerful place to end the main content. We've really gone from, grappling hooks in the throat to rocket ships inside the cell to melting muscles and these invisible iron wars.
It's a microscopic battlefield. And hopefully you can now see that disease isn't just a bug's name. It's a specific mechanism interacting with a specific host defense. It's a process.
Before we wrap up with our recall questions, I want to leave the listener with one last provocative thought you mentioned in our pre-show chat. The concept of the pathogenicity island.
Yes. This is, to me, the scary and fascinating future of microbiology. We tend to think of a species like E. coli as being either good or bad. But bacteria trade DNA like kids trade Pokemon cards.
Okay.
A completely harmless E. coli living in your gut can receive a packet of DNA, a pathogenicity island, from another bacterium via a virus or a plasmid. And this island contains all the genes for, say, a type 3 secretion system and a Shiga-like toxin.
It just downloads a complete weapon pack.
Instantly. In one step, harmless commensal becomes a deadly pathogen. Virulence is modular. It can be moved around. It means new pathogens can emerge, not over millennia, but literally overnight, just by swapping a few genes. It really challenges our whole definition of what a bacterial species even is.
That is definitely something to chew on. Okay, let's verify that you, our listener, have actually been absorbing this stuff. We have 5 rapid-fire SBA-style questions. I'll give the scenario, pause for a moment for you to think, and then our expert will give the answer and the logic.
Ready to go? Let's apply what we've learned.
Question 1. A 24-year-old patient with cystic fibrosis presents with a worsening cough and green mucoid sputum. The lab isolates a gram-negative rod that produces a specific alginate biofilm and an exotoxin, exotoxin A, which inhibits protein synthesis by modifying EF2. What is the most likely organism? Short pause.
The answer is Pseudomonas aeruginosa. The logic here is multi-layered. The biggest clue is cystic fibrosis. That's a classic association. The alginate biofilm is another huge pointer. And finally, knowing that exotoxin A shares the exact same mechanism as diphtheria toxin ADP, rebosylation of elongation factor 2, seals the deal.
Perfect. Question 2. A patient arrives at the emergency room with descending flaccid paralysis. It started with drooping eyelids and difficulty swallowing, and now their weakness is spreading downwards. They mention eating some home-canned vegetables the day before. The toxin involved blocks the release of which specific neurotransmitter? Short pause.
The answer is acetylcholine. This is a textbook case of botulism from Clostridium botulinum. Home canned is the risk factor. Descending flaccid paralysis is the key sign. The toxin cleaves the snare proteins at the neuromuscular junction to stop the release of acetylcholine, which is the go signal for muscle contraction. No signal, no contraction, resulting in limp muscles.
Excellent. Question 3. A young woman suffers from recurrent urinary tract infections. She's now diagnosed with pyelonephritis, a kidney infection. The causative strain of E. coli most likely expresses which specific adherence factor that allows it to infect the upper urinary tract? Short pause.
The answer is P. pili. Remember, common cystitis or bladder infection can be caused by E. coli with type 1 pili that bind to the bladder. But to climb all the way up to the kidney, the bacteria needs the specialized P. pili, which bind to the P blood group antigen found on the epithelial cells in the upper urinary tract. P for pyelonephritis.
Great mnemonic. Question 4. A patient is in the ICU in septic shock with a high fever, severe hypotension, and laboratory signs of disseminated intravascular coagulation, or DIC. Blood cultures are growing a gram-negative rod. Which specific component of the bacterial cell wall is primarily responsible for triggering this massive cytokine cascade? Short pause.
The answer is lipid A. You could also say endotoxin or lipopolysaccharide, LPS, but lipid A is the most precise answer as it is the toxic moiety. Gram-negative shock is driven by lipid A binding to TLR4 and CD14 on macrophages, causing the massive release of IL-1 for fever and TNF-alpha for the hypotension and shock.
Fantastic. Last one, question 5. Which bacterial toxin shares the exact same molecular mechanism of action ADP ribosylation of EF2 as Pseudomonas exotoxin A? Short pause.
The answer is diphtheria toxin, produced by Corynebacterium diphtheria. This is a classic mechanism match question that shows up on exams, both diphtheria toxin and Pseudomonas exotoxin, a target elongation factor 2 to shut down protein synthesis, even though the clinical diseases they cause look completely different.
How did you do? If you missed any of those, it's a great opportunity to go back and re-listen to the toxin factories section or the gram-negative section of our discussion.
And remember, don't just memorize the name of the bug, visualize the weapon it's using.
Thanks for diving deep with us. Keep questioning the mechanism, and we'll see you in the next episode.
Stay curious.